I just wanted to kick things off here. My name's Ben. I work at Phamily, and we've been hosting these Q&A sessions. I think this is our fifth one now we've done in about a little over a month. You know, we just really have noticed that there's a lot of people out there with a lot of questions about CCM. So we want to have this Q&A session where folks can come and bring their questions. And we have a little presentation to kick things off from my colleague Darshan here with a deck, but to talk about enrollment. But really, this is, we want this to be for you. And what we really want is for folks to, sort of bring their questions, and we can sort of help answer those. And yeah, if at any time you sort of have a deeper question that you want to ask, feel free to press the button on the bottom to raise your hand, and I can unmute you. You can also type it into the chat if that's easier, or if you want, you can just type into the chat deep dive, and we'll follow up with you later. We're happy to do 15-minute CCM consultations with anyone. So we can just schedule that later. So if you have if you want to have that discussion one-on-one, just type deep dive into the chat, and we'll do that. We also have, I just want to also note that we have a couple of poll questions that I can put up on the screen here and ask folks in order to just get things underway, so we can have a sense of where you all are with CCM, just so that what we say is relevant, and whether you're just starting or whether you're you've been doing CCM and you have questions about enrollment. So first of all, I'd like to, before I even do that though, I'd like to ask folks, I know Darshan already asked Rose, you're dialing in from Mississippi, and you said you're at was it pediatrics?
Internal medicine.
Internal medicine, excuse me.
Yes,
that makes more sense. Yeah, if other folks want to just stay where they're dialing in from. I know, Julie, do you want to start? I know that you're.
I can start. I'm Julie. I work for Phamily, and I'm a patient advocate here. Been here since the 1st of January. So I help enroll patients. After we send out the text, if they don't reply, then I'll give them a call and get patients enrolled that way. So
great. We have a couple of folks from Phamily. We have some clients that we work with. It's nice to see all of you. And I know we've had several more people join here in the last 60 seconds or so. And for everyone that just joined, we really encourage you to, we want to make this a workshop. It's meant to be interactive. We want to get to know you, understand your questions, and do our best to answer them. So if you're able to, turn your video on. And if you're not, feel free to unmute yourself and speak up. And yeah, would love to get to know you. So anyone that just joined, if you want to either speak up or chat in where you're from and where you're dialing in from, that would be great. I see Sachin. Great.
Hi, this is Sachin. I'm from Modesto, California here. I own a primary care practice, a solo provider.
Great. Thanks for joining.
Caroline says she's dialing in from West Virginia and does internal medicine.
Right.
Yeah, I don't know, Amy or Amy does Covington, Louisiana, also internal medicine. A lot of internal medicine here. Wonderful. And I don't know, Amanda, are you able to? I don't know if you're. Not everybody's. We got her. Illinois chronic care coordinator. Good. And Mary Ray, do you want to say where you're from?
think Mary, right? You must be on mute.
I am from MedPlus in Tupelo, Mississippi, and I'm the chronic care nurse here.
Awesome.
Wonderful.
And then I know we just had Nisha join as well. Hi, Nisha.
Hi, how are you? Sorry, my video's not working.
Oh, that's okay. You want to tell folks where you're dialing in from and what kind of practice you have?
Sure. So I work with a practice called RC360. We are a nephrology practice, mostly based with clients in the Georgia area.
Awesome.
Great.
Okay. Well, well, thanks everybody for doing our little icebreaker and saying where you're from. I'm going to launch a poll here, asking folks how familiar they are with CCM, and if you could just pick one of the 4 responses, it'll help give us a sense of where everybody is.
47 or 47? Oh.
All right. Okay. Give you 5 more seconds if you haven't already. And there we go. So we got most of the folks here are currently doing CCM. We've got someone here who's planning to do CCM. So good for us to know. Just we can talk about it all, but just gives us a sense of where everybody is.
Great.
And then so I guess we can start off here with Darshan. Do you want to just talk a little bit about enrollment, and then maybe that'll spur some questions for people, and we can just take it straight to the Q&A.
Yeah, perfect. We've got a couple of things to show you. I just want to spend maybe 3 or 4 minutes on that piece, and then really open it up and get your questions, comments, have you all talk to each other. I know we have some folks that we work with right now on this workshop, and want to encourage you to talk to each other. So Ben, yeah, let's get going on this, and we'll get through this pretty quick. So yeah, you can, if you want to advance one. Perfect. So what's really interesting, and what we hear all the time across the country when it comes to chronic care management, is how many folks have trouble with enrollment. Just getting a good number of patients enrolled in the program. And the irony here is CCM has been proven to be a really valuable program for patients. So Medicare's own analysis shows that for patients in chronic care management, quality goes up and the health outcomes of those patients get better, to the tune of patients in CCM, their hospitalizations and ER visits decrease by 5%. And as you all know, providers, medical groups, going to get paid a healthy amount of money to do the work. And you would think that with both of those things being true, quality goes up, ER and hospital visits go down, and providers are getting paid to do this work, you would think that the vast majority of Medicare patients would be enrolled, but it's not even close to that. So our best estimate is, as of now, only about 7% of all eligible Medicare and Medicare Advantage patients are enrolled in CCM. And there's several reasons why this is the case, but one of the ones that we hear most frequently is medical groups don't know how to enroll patients quickly and how to get to a decent scale. And that's what we're going to be covering today. And if you want to go on one. So when you look at the most recent public data from Medicare, which is from 2019, the average CCM program in the country only had 82 patients enrolled in CCM. And that equates out to that about 6 or 7% of total patients. So these are very, very small programs for CCM. And the key, one of the keys here is most providers that are trying to do CCM, their way of enrolling, their default thinking of how do I enroll patients is they're waiting for those patients to visit the office. And what's interesting is the average Medicare patient is only visiting their provider, let's say about 4 times a year. We know that from the data. And so if you're just waiting for patients to come into the office, your numbers are going to be low and it's going to be slow. You're ramping up, you're trying to ramp up this program, but you're just waiting for patients to walk in the door. There is a different, more proactive way to do it, which we really encourage, and we'll talk a little bit about how to do that. And one of the other obstacles that we hear about all the time, and happy to talk to you about this, is many groups don't even start a program because they're so afraid about talking to patients about potential cost sharing. And I've heard from so many very large groups, hospitals, health systems, big medical groups, that this is the only reason why they're not doing it. But the reality is, and we see this in our data, we see it in the national data, 70% of eligible patients have a supplemental plan that helps cover the copay. And also, if it's a good program, if it's a good CCM program that the patients actually appreciate, that is adding value to them, even the patients that do have some cost sharing responsibility, they're gonna pay it because they feel like the program is adding value to their life. But just from a starting point, the majority of patients are gonna have their copays covered. So this really shouldn't be an obstacle. And if you wanna go to the next one. So what we've seen is medical groups that rely only on visit-based enrollment. They'll be lucky to enroll 20, maybe 40 patients over the course of the first 2 months. And it really calls into question, the speed, the scale of these programs. And at that scale, is the program even worth doing? Because it's quite a bit of effort. And I know you all know this, especially for the ones that are doing CCM. And what we've seen from groups that take a more proactive approach to enrollment, you can get almost 10 times higher enrollment if you apply a more proactive approach. And the data that we see through the methods that we use with our clients is for every group of 1,000 eligible patients, the most recent data is you can get 330 of those patients enrolled within 60 days, which is a night and day difference. And a lot of that has to do with, again, just being proactive, letting your patients know that this service is available. And I think a lot of people will be surprised to know that there's a lot of demand for this. There's a lot of demand for patients that feel they need more support. They want this support. We just got to get that message out to them. So what do I mean by proactive enrollment? It is really about not just waiting for patients to come to the office, but sending a series of messages. They can be text messages, for example, and following up, as Julie was alluding to earlier, following up with phone calls to engage and ultimately enroll these patients. And what we have seen is that a series of messages, and for us, kind of the optimal number we've seen is 4 messages going out over about a 3 to 4 week span, is the optimal number of messages. And the messages have to really focus on 2 things. It's trust and credibility. So the patient needs to feel, hey, this is coming from my provider's office, from my medical group. I recognize that name. I see my doctor's name in there. That's one. They have to trust it. And then number 2, it's got to speak to the value that the patient is going to get out of the program, right? Patients don't want to be reminded about their chronic conditions, things like that. What value are you as a provider group going to deliver to these patients through this program that will get them excited about it? And as I mentioned, if you do this correctly, you'll see about a 33% enrollment rate. And in addition, it's not to say that visit-based enrollment doesn't work. It's a good layer on top of the proactive outreach-based enrollment. And a couple of key things that we've learned about visit-based enrollment is, as much as possible, you want to make introducing and talking to your patients about CCM a natural part of the workflow. And from the moment the patient enters the door to the office to the moment they leave, have touch points throughout that workflow that are telling the patient, giving them a heads up about this program. Hey, the doctor is going to want to talk to you about this. We think this will be a good program for you. And doing as much of that work as possible to minimize the work on the provider. And once you get them enrolled, start adding value and engaging those patients via CCM right away. The more you can shrink that time between enrollment and when they actually start to see value, the more engaged and happy those patients will be. So they don't feel like, hey, they talked to me about this, a couple of weeks ago and I haven't seen anything. You want to shorten that time frame as much as possible. And what you can see on the left here, a tool that we found really helpful is, again, making this a part of the natural workflow. We've actually created a prescription pad where all the doctor needs to do is remind the patient about this program, encourage them to join, and really focus on the patient. Why do they think it's good for that patient? And all they do here is circle the chronic conditions and talk to the patient about their health goals. What does the patient want to accomplish? And that then gets translated by the clinical staff into the comprehensive care plan. That's a key component of CCM. So that's all I wanted to cover right now. Just what are the key obstacles that people face? The fact that a way to do proactive enrollment does exist. It's really important to get these programs at scale and then layer visit-based enrollment on top of it. So with that, I really wanted to open it up for questions, comments, discussions that either Ben or I might be able to answer and Julie might be able to answer, or questions that you might have for each other. So you can feel free to unmute yourself. Ben can unmute you, or you can type your questions into the chat box. And don't hold back. We're game for any type of question that you have.
So I just wanted to kind of add to what Darshan said about, because the previous program I came from, the chronic care program was already initiated. The employer that I'm at now actually started it from the ground up, and my employer at the time would not let me begin the program with Phamily. So I actually started the old-fashioned way that he's referring to, the cold calling and the waiting on them to come into the office for a visit to try to enroll them. And I was stuck at about, after about a month, I had about 60 enrolled. So after I began using Phamily, as I did before at my previous job, we went to 462 in around just a matter of weeks. So, I can testify to its effectiveness as far as that goes.
That's great, Mary Ray. Thank you for sharing kind of that before and after picture that you've experienced. That's helpful.
So I would just like to input. My name's not Debbie, by the way. I'm logging in through her information. My name is Nancy, and I work at a gastroenterology office. So we started this program in November, and it was kind of overwhelming because I'm the only one working on it right now. And we had some pretty big hiccups that we ran into right from the beginning. But we ended up with approximately 600 patients enrolled in the program that fit within our parameters. Last week on the 15th, we sent out a new outreach, and our numbers from that outreach have grown. That one and the one we sent out yesterday have grown from the 600 to about 1,500. So I'm looking for some help. But yeah, it's increased tremendously here.
Nancy, it sounds like thanks for sharing that story. It sounds like the enrollment might have worked a little bit too well.
Yeah.
Can I ask Deborah a question?
My name's Nancy.
Sorry, Nancy.
That's okay.
So you have 600 patients enrolled. Do you make contact with all those 600? I guess now you have 1,500, but do you make contact with all those patients every single month and bill out for that every single month?
No. We are still in the process of having care plans created that fit our diagnoses. So unfortunately, I'm not allowed to reach out to all of those as far as billing for the month yet. But we probably have, for January, we had 32 patients. For February, we 81. And for March, I'm looking at probably closer to 200 that we will be able to for.
That you have like care plans for and or like actively enrolled, I guess.
Yes.
Yeah. Okay.
I wanted to just add a great question, Amanda. One thing I want to add is the thing about the proactive enrollment is first, think about it as building a panel. You're engaging these patients first, letting them know this exists. And then it's a process, of course, to officially get them enrolled in CCM. You've got to build out the care plan. You've got to make sure you have the consent conversation. But the key is to engage them and start delivering some value versus waiting for months for them to walk into the office. That's the key. And then Amanda, happy to, if you would like, happy to chat more about the statistics around patient engagement and how many get to billable events, but I'll leave that up to you. Other questions or stories that you want to share about your enrollment and where it is and problems that you're looking to solve?
I think that we are kind of stalled at 70, but the way I did it, I didn't reach out to a large mass of people. We just kind of slowly grew our program. And like I said, we're kind of stalled at around the 70 mark, where I'm contacting all these 70 patients every month and documenting every month and billing out every month. So that's pretty timely. And I do have one support person that her time is kind of more pulled towards the hospital side because we are associated with the hospital. But I do find it a struggle to not have a lot of, I guess, support people that can arrange for transportation, can arrange, call doctor's offices and arrange for appointments, things like that. And I don't know, I feel like there's a way to be more efficient with my time. I don't know what that is. We've kind of talked about maybe me doing dictating rather than typing my notes. But I think probably time efficiency is one of my main struggles right now.
So Amanda, are you a current Phamily user or you the one that was not?
I'm not a Phamily user, no.
Okay, so I totally see what you're saying, and I think everyone probably before they used Phamily experienced that same difficulty that you're having. So the previous employer I worked at, Rose and I actually worked together. We didn't mention that at internal medicine before I came to the location I'm at now. So when I started at that program at IMPC, they had chronic care in place, but they did not have Phamily in place. So when we switched to using Phamily, they went from around the most, I tracked numbers for a year before I got there, and the most they were billing was 150. After we started to use Phamily, we were able to bill 600 to 700 every month, and Rose is still currently billing at those numbers. It's just a much more manageable, scalable system than anything else you're going to find. And I tell you that because I've done it the other ways. And you're going to run into the same problems that you're expressing here.
Thanks for your input.
And Amanda,
And I'd be glad to share more if you want me to put my email or contact info in the chat. I'll be glad to do that also.
Oh, that'd be awesome. Thank you.
Okay.
Amanda, I want to pull a bit on your thread, and thank you, Mary Ray, for the detail that you added. The thread I want to pull on is two things. One is, and the theme here is, how do we break down some of the old default mindsets in terms of what does enroll? How do we do enrollment? The default mindset is you got to wait for patients to come in, or maybe you got to cold call these patients. Another default mindset is, once we get these patients, how do we take care of them? Well, we got to call them once a month. And that takes a lot of work. And Amanda, as you said, it takes a lot of, not only you have to call them, then you have to sit there and document everything that happened. And so it's worth, looking at your program and thinking, what are those mindsets I'm bringing to it, and how do I break those down and think about these things differently? So going from reactive enrollment to proactive, going from, as Mary Ray talked about, kind of phone calls where it's very manual documentation, to how do I do this and find patients and engage with patients the way they want to engage. And there's various ways we can do that that I'm happy to talk about.
I feel like with our practice, it's not so much even a matter of getting patients. We have, oh gosh, I think I'm probably saying this wrong. I think we have like 7 clinics. And so we have several different family practice providers, and they do send me referrals. So I feel like it's not even a lack of referrals. It's just a matter of me getting to them. And then, like you said, the monthly time that it takes to make these monthly contacts.
Got it. So Amanda, what I'm kind of gathering from you there is your method for your 70 patients right now is you're reaching out to those patients with a once-a-month phone call.
Correct.
Okay. Got it. And we can chat about that. I want to mix this up a little bit and see other folks. I know we've had a couple more people join in the last few minutes. And what we're here talking about is the barriers to enrollment, those obstacles, and how do we overcome those obstacles so you can actually have a CCM program at a decent scale where you can help more patients and improve more quality. So I want to open it up again to the audience and see what questions, concerns, what are problems that you're running into that any of us can help you think through. And you can either feel free to unmute yourself, or you can ask the questions in the chat box.
Shanti, did you have a question? I saw you unmuted. You're unmuted. Oh, perhaps not. But yeah, if anybody else has any sort of questions around CCM enrollment, running your CCM program, we're coming up on 11 o'clock, or excuse me, 1 o'clock here. So I know that some folks may have to go, but we're happy to hang around if folks still want to sort of keep the conversation going for a little bit here.
Ben, I'm just gonna. I know we've heard from some folks, and I'm just curious for some of the folks that we haven't heard from. So Amy, for example, you mentioned you're from Covington, Louisiana. You're in an internal medicine practice. If you're still on and available, would love to hear how things are going with you and how have you solved the enrollment problem at your practice. Amy might have stepped away. We can give her a minute. Anybody else? Questions, comments, problems that you're running into that we can help you think through?
Hi, this is Sachin. Sorry, I'm in and out because I have to take care of some calls. What do you guys provide? I didn't hear much from about what Phamily does.
Sachin, good question. We are the #1 text-based CCM solution in the country, and we basically help provider organizations do CCM in a more scalable and sustainable way. And we provide the technology, the workflows, and the support that providers need to run these programs at scale. So basically think about it as we give you the technology and the support, and we do everything except the actual care management, because we're big believers that the practice should be doing the care management for their patients. We're not doing the care management. We're giving you and your team the tools and the superpowers, so to speak, of how do you do this in a much more scalable way, where you don't have one person taking care of 60 or 70 patients. You have one person taking care of 500 patients. So we give you the tools and the workflows on how to do that.
The challenge I have is in a semi-rural area, a lot of the senior patients that I deal with, we don't have this text options, or even if they do, it's hard for them to communicate on that scale. Is that text only, or do you actually have all touch points in terms of outreach?
Yeah, texting is kind of the cornerstone. And it's interesting, we've seen in markets across the country, from urban to extremely rural areas, that the engagement is high. You might have a different population, but it's not the only way. Basically, think about it as you want to communicate with your patients in multiple channels. It can be texting, adding phone calls, etc.
Oh, sorry. Hold on. There you go. Sorry about that.
Okay, that's okay. So we have some patients here that are phone call only. You know, they don't do the texting. So those are reached either via email. Sometimes they will communicate through email, or I give them a call and talk to them directly. So there are other options if some patients don't have the texting capability.
Yeah, Nancy, great point. And it's what we see across our data. About 80% of patients, including in rural areas, will engage via texting on at least a monthly basis. And then there's usually 20% that either they've got a landline, or they might have a caregiver that's taking care of them. That caregiver may engage via text or over the phone. But the vast majority we've found prefer simple texting.
Yeah, and I think that one key too is the nature of the text. I mean, a text that, one thing that I've sort of heard about what works and what doesn't is that a text that just asks, how are you doing, and sort of puts the burden on the patient to kind of come up with their own information can be, not as engaging. One thing that we do at Phamily is, that the text is connected directly to the care plan. It's sort of asking specific questions about the goals they're trying to reach. And, if you have sort of an engaging beginning to the text, then that can sort of get the conversation going versus, just sort of getting the, how are you doing on a regular basis. That kind of feels a little like a burden. You got to come up, it's like, oh, what am I supposed to say again? So sort of the nature of the text matters too.
Dan, can I add to that?
Sure, of course.
So just in my experience, we did have several patients that would prefer us add their caregiver or their family member, add their number to the family account. And that's worked very well for me in the past. And also, Sasha, and I would add that even those rural areas, they may not be able to respond to you at that exact time that the message is sent. But when they are able to get to an area with service later, or it's a more convenient time for them, then they can still respond at any time. And that's the good thing about Phamily and versus monthly calls, is the patient is able to respond when they need something. It's very proactive. If I call you on Tuesday at 10, that may not be a day that you are needing anything, and you've missed the whole point of the proactive care element here. So the text, even in the rural areas, I think it would still work for you.
All right, thanks.
And Mary Ray, you bring up an interesting point, and it's another mindset that we see folks are shifting, and we're working with folks to shift, which is, again, the default behavior is, I'm going to call these patients once a month and try to make that call a 20-minute call. The guiding light that we work on is how do we enable really good care management at a large scale, but it starts with really good care management. And really good care management is centered around frequent, proactive communication with patients. It's not a check the box, I'm going to get to 20 minutes. It's about how do I engage in a stream of communication with this patient where they feel supported, they feel cared for, and they know if anything is going on with them that they need help with, they can reach out to their care manager themselves. They don't have to wait for a monthly call. So that's the mindset that that the groups that we work with are shifting to. And we work with also a lot of hospitals, large medical groups that are further down value-based care. And there's broad-based agreement that if you can engage patients more frequently, it gives you more opportunities to help those patients. So for all of you that are either doing CCM or planning on doing it, I would really encourage you to think about not just how do I get 20 minutes a month, but how do I engage patients more frequently, if that makes sense.
I was just going to add off of what Mary Ray was saying. Can you hear me?
Yep.
Okay.
Yep.
I'm just going to add off what she was saying is that we have over 900 plus enrolled in Phamily right now, or in CCM, I'm sorry. And okay, there are some that does not participate or choose to text with family, although their caregivers do. Like Mary Ray was saying, there are a lot that text after hours, 2, 3 o'clock in the morning, the weekends. And then when we reply to them, they still appreciate it. We're still being able to give that quality care to them. Along with the check-ins that we do each week, they may not reply right away, but they will answer the questions later. At least they know that we're there.
Wonderful.
Absolutely.
Thank you, Rose. And I know we're over time, but it sounds like, it looks like, some people are hanging out, which is great. We've got, Ben and I have got another 15 minutes or so, and definitely encourage you to raise your questions. It doesn't have to be just about enrollment, but anything that's on your mind.
So I guess with that text that goes out to these patients, does that automatically get put into their chart, or how does that get documented?
Yeah, really good question. And Amanda, just so I can answer that correctly, are you saying the enrollment messages or just any messages going back and forth for the care management?
I think any message going back and forth, because you said the questions that get sent out are kind of based on the care plan. So I just wondered how that was documented. Yeah,
so really good question. The principle here is for folks like you, Amanda, that are running these programs, and Rose and Mary Ray, how can we get you spending the vast majority of your time actually helping patients and engaging patients, and less of your time doing manual documentation? That's the key, right? That's how these things can become sustainable, and they can grow, and they can actually improve quality. And so the messages, Mary Ray and Rose can attest to this, but twice a week, our provider groups send out messages that are tailored for each patient based on their care plan, based on their chronic condition. And really, that's a conversation starter. It's a reminder to the patient, hey, we care about you even when you're not in the office. We're checking in on you. They could reply to a question about their medication with something totally different, but it's something that's important to them at that point in time, right? So those messages go out twice a week. Those are conversation starters. And then patients reply. It might be the same day, it might be the next day. And every message back and forth is automatically documented. So you don't have to then engage with these patients and then spend another 20 minutes typing your engagement. It's already there.
Wow. Okay. So that's how you can see so many patients in the program. I get it.
That's one. Because when you think about the phone calls, right? We've talked to so many providers that have tried it that way, and to Mary Ray's earlier numbers, 50, 70, what you were saying, Amanda, that's kind of the natural limit of, if you're trying to call patients once a month, it's really hard to get past that because it's so time intensive. It's so hard. So messaging enables you to help more patients, and quite frankly, to help them more often, right? To engage them more often, and it reduces the administrative time. So you're not doing a 20-minute phone call and then spending 20 minutes typing. It takes that documentation time away.
Because in Phamily, when you're talking back and forth, it's going to look like a texting thread as it does in your cell phone. So, and it keeps tracking that patient's individual chart in Phamily.
That's great. That's cool. I have a better understanding of this program now. At first, I was kind of not clear on how this all works, but I appreciate that. I understand this better now.
Great. And Amanda, I'm just curious, from your perspective, it sounds like you've been growing the program, you've been managing it. It's 70 out of how many eligible patients would you say?
Oh, I don't know. I don't think I've ever really looked at that number before. I think maybe like 3,000 some, maybe.
Okay. Okay. So that's another thing I really, for anyone that's doing CCM or thinking about it, one of the key metrics you want to think about is what percentage of my eligible patients am I helping? Do I have enrolled? And a good benchmark to get to is 40%. And it's doable. That's a good thing to strive for, because your quality will go up and you're going to be able to find more patients that need help and help them at the right time. So 40% is a number to keep in mind there.
I'd like to address, another barrier that a concern I had before I started using Phamily, and that was, you think about this is an older population base, and you're wondering, okay, well, how many of these 70 and 80-year-old patients are actually going to text? And I was pleasantly surprised that, I would say 90% or 90% text back and forth very interactively. And also it kind of makes them, just having the text option, like Rose said, it makes them feel like somebody's always there and available. If they can put one person's name and a number at that clinic that is their contact person, and they can text, it may be something they don't want to talk in person about. It's emotional for them or anything. I've had patients tell me, hey, you're the only one I have that checks on me. So I feel like it's just a very reassuring element for them to be able to text on their timeline.
And to add to that, when patients don't reply to those outreach texts and I'm giving them a call, a big factor for them is that fact that, oh, I can actually reach out on my own, not have to make a phone call and hope somebody calls me back. That was a big factor to actually enrolling, is to know that they can text whenever they need to. It was huge for them. Not just the fact that somebody's calling them or texting them every month, that they can actually participate and let them know when they're having a problem. It was a big factor.
Thanks, Julie, for sharing that. I know we've run long here because there's been a bunch of good questions and a bunch of good discussions. We like to do these workshops really to provide value for you all. I know there's a ton of questions about this stuff. People run into a bunch of obstacles, and we want to be able to help. My team is also able to do free, quick consultations. If you want to dive deeper into any of these things that we talked about, how do you even figure out how many eligible patients do you have? How do you enroll them? What does that look like? how do you do the care management where it's not just a once a month call? If you want to dive deeper into any of that, Ben has put up here my information. You can schedule an appointment. I'm happy to talk to you. I can get my team to talk to you. We're available and accessible, and we're happy to talk about this stuff.
Yeah, and I'm gonna send to everybody who attended. I'll send this presentation. It says click here. You'll be able to click there. I know it doesn't make a lot of sense when it's just on the screen, but I'll send out a video of this of the workshop as well as a follow up, so you all have that.
Wonderful. Well, thank you everybody for joining and spending your lunchtime with us talking about this. And we will see you next time. Reach out and let us know what we can do to help you. Thank you, Mary Ray. Thank you, Rose. Thank you, Julie.
You're welcome. Thank
You're
you.
welcome. I enjoyed it.
All right, thanks everybody.
Bye.
Thank you. That was great.
Bye.
Bye.